Hello, everyone, and welcome once again to this lovely CCI webinars, which we have every Thursday. It's almost as if all the pulmonologists from India block Thursday 8 p.m. exclusively for CCI, which is such a wonderful thing to do. And at the outset, this is a very special series for me because this is the first webinar of the lung transplantation series, which we're going to explore. And this is very, very, very close to my heart. And I'm sure all the panelists also will agree with me. It's very close to their hearts as well. Before we obviously dig into this topic, I would like to thank Dr. Krishna sir, Dr. Narayan Pradeep sir, Dr. Ashish Dubey, Dr. Anil Maske, Vijay Kumar, Chennamchetty Garu, who is yet to join us as a panelist on this. And of course, so many people who work tirelessly behind the scenes, ensuring that every Thursday we have got these webinars. It's a very simple topic. As I mentioned, this is the first topic. So it's, lung transplantation to differ or, to refer. So we're just going to have very basics about lung transplantation. What do you mean by lung transplantation? What do you mean by the referral criteria? What are indications, contraindications? So very simple presentation. And then we will take forth a case-based explanation and a discussion with my esteemed panelists. So this is the content of the talk for today. So the introduction for lung transplantation, what are the indications, contraindications? What exactly do you mean by this concept of a transplant window? What do you mean by referral criteria? And when I say referral criteria, is there something available in black and white so that it is very simple for the referring pulmonologist or anyone in the community to refer such patients? What do you mean by barriers for referral in India? Is there really a barrier or is it just a myth? And of course, I will sum it up with a conclusion at the end. So obviously, lung transplantation, it's without a shadow of doubt, this has emerged as a definitive treatment option. All end-stage lung diseases, whenever medical management has been optimized, the patient's condition is still worsening, it is advancing. That is obviously when we have to refer for lung transplantation. In India, obviously, there are a lot of centers which have developed. There are a lot of centers which are in the process of developing. But obviously, with an ever-increasing population and an ever-increasing burden of chronic lung diseases, we need much more to be done in our country. Now, what exactly, very shortly, what are the indications and contraindications? Actually, if you look at this page, it's every pulmonologist who will look at this page will simply understand that any chronic lung disease, as I mentioned, when we have completely optimized these patients medically, physiotherapy wise, nutrition wise, still advancing, that is when we need to refer for lung transplantation. It's a simple classification of all chronic lung diseases, something which all of us see day to day in our busy OPD. So the first obviously is diffuse parenchymal lung diseases, which includes all your ILDs, so your IPFs, your sarcoids, your hypersensitive pneumonitis. The reason I'm mentioning HP is because in India, as all of you know, almost 45%, 40 to 45% of all the ILDs are in fact hypersensitivity pneumonitis. And of course, there's a big setup of connective tissue disease related interstitial lung disease. So we need to, work closely together with our rheumatology colleagues as well. The second column belongs to all the obstructive airway diseases. Now, while if you go to the West, smoking related COPD is a huge thing. IPF has obviously just overtaken COPD in terms of referrals in the West. In India, what we see is that even non-smoking COPD is a huge entity. All of us know Dr. Sandeep Salvi sir has done some wonderful research, which is there on international platforms on this. And plus, obviously, with Diwali, there is so much of talk about AQI and air pollution and worsening air pollution. Obviously, all of this also contributes to your underlying airway diseases. And of course, do not forget, since we are Indians, all of us are somehow associated with tuberculosis. So post-TB obstructive airway disease will also come under this category. Third is obviously all the pulmonary vascular diseases. Now, I'm giving a very special mention to pulmonary hypertension. So this is a very difficult disease. Practice still says, in our country, you will see that pulmonary hypertensions, in fact, are managed more by cardiologists compared to pulmonologists. So we do have quite a few referral bases of these patients with the cardiologist as opposed to the pulmonologist. And last is again a very important category, which is a chronic suppurative lung diseases. By this, I basically mean bronchiectasis. In our country, the most common will be post-tuberculosis bronchiectasis. Cystic fibrosis is not something which we see very commonly. It's more commonly seen in Scandinavian countries. You'll see it in UK. You will see it in Canada. But in our country, even though we do have an active CF registry, but still, frankly, CF is not something which is our daily walk-in, walk-out patients in our clinics. Now, contraindications. Now, this is a huge debate by itself, and we will obviously be talking about this with our esteemed panelists in some time, in more detail. So, if you actually go through this, there are certain things, you've got your heart, you've got your malignancy, you've got your deranged renal function, your liver is gone, septic shock, active TB, you've got some very bad extrapulmonary or disseminated infection. So there are a lot of these things. Obviously, progressive cognitive impairment, you've got very limited social support back home. And a very important box in this, which I would say that belongs to a gray area, is limited functional status, with a poor potential for post-transplant rehabilitation. Now, what exactly this means, what are the implications for this, we will be discussing with our panelists in more detail as the webinar progresses. Now, it's a very interesting concept of a transplant window. Now, every transplant pulmonologist in this country, and we have got two very eminent transplant pulmonologists. We've got a very eminent transplant surgeon who's also watching this. Everywhere we go, every PPT that we do, we will always have this colorful photo, because it helps in explanation to patients. It helps in explanation to referring pulmonologists or to community at large. Okay, so we've got this very colorful thing. Right at the start, the patient is too well to undergo the transplant. That is the yellow zone. Obviously, once he comes to the green zone, that is known as the transplant window. So transplant window is the period in which a patient needs a lung transplantation. However, the patient is fit enough to undergo the lung transplantation. It's a very important concept that he needs it, but yet he is fit enough to undergo it. Because once the fitness keeps going down, all of us are seeing the lateral part of the graph, which is completely the red zone in which a patient, it's unfortunately, we are too late and we are just looking at an expensive mortality if we go ahead with lung transplantation. Okay. Now, I'll tell you a very interesting thing and a very funny thing. We always come, all the transplant pulmonologists, we show this slide and everything. And we always are asked this question that, this is a very good looking slide and all of that, but we need things in black and white. What do you mean by early referral? Because your early can be my late, my early can be your late. Okay, so there is a always relative concept when we are looking at this particular graph. So is there something available in black and white indices, objective parameters for referral? The answer is yes. And this is the paper which I would like all of you all to go through. This has been published in the Journal of Heart and Lung Transplantation. This is available on the official website of International Society for Heart and Lung Transplantation. This is an update in 2021 in which every single disease, we have got proper criteria of when to refer and when to list, so that there is objectivity in all these patients instead of subjectivity. A matter of national pride for all of us. One of the contributing authors in this particular paper is Dr. Sandeep Attawar, sir. All of us know, and Vijil boss is a part of this this panel, and I'm sure he has had a lot in terms of contributing towards this paper. Now, what exactly do I even mean by showing this paper? What exactly do I mean when I say black and white? Okay, I'll just like to give examples. I'm taking two examples. So first is we need to understand that lung transplantation obviously should be considered for people with chronic end-stage lung disease who meet the following two criteria. So first is there is a high risk of death from the lung disease more than 50 years within 2 years. And second, which is a very, very, very important statement, there is a more than 80% likelihood of a 5-year post-transplant survival from a general medical perspective. Now, what are the two diseases which I would like to give an example? So the first is interstitial lung disease. Now, what do you mean by referral? The next is, what do you mean by listing? Now, remember, now remember, every transplant center which works in different cities, when a pulmonologist refers a patient or needs to refer a patient to the transplant center, that criteria is known as a referral criteria. When the transplant center completely evaluates the patient and they decide to list the patient for transplantation, that is known as the listing criteria. So this is the referral criteria for ILDs. Now, the first point is a very simple point. Of course, when you're dealing with an IPF or a UIP pattern, the second is a very funny thing, is something which we will come to later. This is a spirometric criteria in which your FVC is less than 80% or your DLCO is less than 40%. It's a very controversial thing. We will come back to this in the discussion. Third is obviously understandable when you have a spirometric fall. So it's a relative decline in your FVC and in your DLCO by 10 and 15% respectively. Fourth is oxygenation requirement. So any supplemental oxygen, whether it is LTOT, whether it is intermittent, whether it is on exertion, again, should prompt a referral to the transplant center. And fifth and sixth point are more to do with inflammatory ILDs and connective tissue disease ILDs. All it mentions is, if you are dealing with these patients, just refer the patient early to the center. It does not mean that we are going to urgently transplant these patients, but all it should do is it should prompt a referral, because these are funny patients, these are weird patients. Remember, they've got a lot of extra pulmonary things which are going on in the background, which can determine their success or their clinical course. So we need to keep this in mind. Again, as far as ILD is concerned, what do we mean by listing? So when the patient has already come to the transplant center, obviously the first is when there is an absolute decline in your spirometry. The second is 6-minute walk test in which your desaturation is less than 88%, or serial 6-minute walk distance which has been done. There is a more than 50 meters decrement in the distance in the last 6 months. Any amount of pulmonary hypertension, whether it is on an echo or on a right heart catheterization. Remember, in the general setting, right heart catheterization is not something which is done very frequently, but we are talking about a specialist transplant center where obviously you will have access to this. But an echo is something which is available every single place. So the initial development of pulmonary hypertension is also time to list the patient. And last is any hospitalization because of a respiratory decline. It can be an exacerbation, it can be a pneumothorax, or it can just be a simple worsening of your disease. Now, these are something which we clinically see as listing criteria for these patients. Again, I would like to give you an example. The second case is, let's take COPD. So when should a referral be prompted by the general pulmonologist? If you see, when the board score is 5 to 6 with any of the additional factors. For example, if you have the frequent acute exacerbator variant, if you feel that your board score has increased more than 1 over the last 2 years, if you feel that on the CT scan, your PA is to aorta diameter is more than 1, which basically refers to an increased, it's like pulmonary hypertension when your diameter completely of the pulmonary artery is more than your aorta, or your FE1 is 20 to 25%. So obviously we are talking about the severe and the very severe variants of COPD. The second point is, despite maximal treatment, okay, so all your rehabs have been done, oxygen therapy has been done, everything has been done, but still your patient is deteriorating. That is again when you need to refer. Third is a poor quality of life. And fourth is, it's a very interesting point, you need to simultaneously consider referral to a lung transplant program, and if available, refer for a lung volume reduction surgery. It can either be a bronchoscopic or it can be a surgical thing, but that timing should be similar for both. And again, what do we mean by listing for COPD? So when your board score seriously progresses, it's 7 to 10. Obviously, all of us know that board score is associated with more, an increased board score is associated with increased mortality in these patients. any additional factors. For example, your FE1 further decreases less than 20%. If you've got moderate to severe pulmonary hypertension on your echo, again, history of severe exacerbations and chronic hypercapnic patients is also a point in which you would like to list these patients. So these are the two examples which I have given. Again, if you refer to this uh, this document or this guideline, you will see that there are referral and listing criteria for bronchiectasis, for LAM, for pulmonary hypertension, and in fact there are also studies right now which is in the forefront being done on lung cancer referrals for lung transplantation. It's a very interesting area which probably in the next 3 to 5 years, I believe we will be having more concrete input and more concrete data. Now, unfortunately, despite there being so much of clarity, despite there being black and white data, we still believe that there are a lot of barriers. Okay, so what exactly are these barriers? Is it geography? Because we've got very little transplant centers and patients from all over India cannot come to that particular center. Is it cost? Are finances a huge, huge thing? Is it a huge barrier? Is there a mistrust between the referring pulmonologist and the transplant team? Do you feel that lack of data? And of course, when I say data, I mean data to be published in peer reviewed journals as well as publication. And last is obviously my face. Unfortunately, I'm not getting any referrals. So is it my face which unfortunately is not getting any referrals? I think we will need to take this up with the two pulmonologists who are going to join us in this panel. So in summary, of course, lung transplant is a definitive treatment goal. There is absolutely no doubt about that. India is doing good, but there is obviously scope for improvement. We need a lot more dedicated transplant centers. And the last, one of the most important lines is early and timely referrals, which holds the key. So do you think India is ready for this? And this is what we are going to discuss in today's panel discussion. So I'm going to temporarily stop my presentation over here, and it is a privilege for me to moderate this session. We've got a host of a galaxy of pulmonologists as well as surgeons on this particular webinar. So firstly, I would like to introduce the whole panel. So first is Dr. Jnanesh Thacker, sir. Sir is a very, very, very dear and a very esteemed senior colleague of mine. I would like to mention that Sir is the first surgeon to perform lung transplantation on an Indian patient in India. Okay, so when lung transplantation was something which was more of a fiction and restricted to examination questions, Sir was the one who actually came and did it, and he lay rest to all the naysayers. Second is Dr. Vijil Rahulan, sir. I call him Vijil Boss. The reason I call him Vijil Boss is because he's one of the best transplant pulmonologists in India. Dr. Vijil sir has got the the distinction of being the transplant pulmonologist with the first lung transplantation to be done in India, and he's still doing such a magnificent job. So he has literally seen the growth of the field of transplant pulmonology in our country. Third is Dr. Tapaswi Krishna, who is all the way from Hyderabad. We have been hearing wonderful things being done in a transplant center, and she's a transplant pulmonologist in Hyderabad. We look forward to a lot of good discussions from Dr. Tapaswi. Fourth is Dr. Indu Bubna, who's one of the leading pulmonologists in Mumbai. Indu has promised me that she will refer at least 20 patients. Unfortunately, she has not referred even one. This panel, we are going to uncover what is the reason and what are the barriers. We've also been joined by Dr. Animesh Jain, who is a community medicine expert. It's a very interesting aspect to discuss about community medicine aspect and lung transplantation. Is there any correlation between the two, or are we reading too much? And in some time, we will be joined very shortly by Dr. Vijay Kumar Chennamchetty Garu, who is also one of the main faces of these webinars. So before I start with the discussion, I would just once again have a very simple case presentation for everyone. Now, remember, we need more of a discussion. So this can be more of a hypothetical case, or we can add and, we can subtract how much ever we want. So we've got a 70-year-old male. The age over here is important. He is a farmer. He's an ex-smoker. Let us say smoking index is 10 pack years or something. He's diabetic. He's hypertensive. Comorbidities also, we just know from his notes that he is a patient of ischemic heart disease with PTCA done to LAD in the past. He has been diagnosed as idiopathic pulmonary fibrosis since 3 years. One of the reasons that I am discussing interstitial lung disease, because all the transplant pulmonologists will agree with me, that is the maximum referrals which we get. So 3 years diagnosed as IPF, HRCT thorax completely confirms it. Now look at the spirometry, it's very important. Now at diagnosis, so 3 years back his FVC was 63%, DLCO was 30%. Obviously they were decreased, but this is the value which we have. Currently, after 3 years, his FVC has dropped down to 22%, and DLCO he is absolutely unable to perform. The treatment going on right now is nintedanib, which is 100 milligram OD is going on for him. Pirfenidone is 400 milligram BD. That's all he's able to tolerate. And last point which I want to mention is he's on intermittent oxygen since 2 years. LTOT is since 6 months. His current usage is 3 liters per minute at rest, in which he probably manages a saturation of 90 to 91%. So this is the case which we've got. I've deliberately left out a lot of parts, and people can obviously ask whatever questions that they want in this case. We will be joined by Chennamchetty Garu in some time. So Dr. Indu, I would like to open with you. You are the opening batsman for this panel discussion. Simple, straightforward, golden question to you. Suppose you are the pulmonologist who has been seeing this patient since 3 years. Okay. So 3 years back, you've seen the spirometry, you've seen the decline. Currently, his FVC is 22%. Simple question to you. Will you refer this patient for lung transplantation? It's a yes or a no, but I am more interested in your thinking behind your answer.
Sure. So thank you so much, Kapil, for making me a part of this webinar and a wonderful initiative to start. Coming back to your case, this patient is basically, yes, first thing I would like to refer this patient for the lung transplantation now. Now, this patient is already a progressive fibrotic ILD patient, with a UIP pattern on the HRCT. And with a progressive decline in the FVC, DLCO could not be performed after 3 years because of his status. But he should have been long referred for the lung transplant when the FVC was below 80% as per the criteria. And he's already on antifibrotics. He's already on oxygen, which is around 4 liters past 2 years. Correct?
Correct.
So, I mean, this should be referred for the lung transplantation for sure. See, my role here is to refer early when the patient is ambulatory and when the patient is nutritionally stable also, before he starts developing pulmonary hypertension or right heart failure.
Again, you used a very important word. You used that my job is to refer this patient early. Now, I would like to hold you on this early in this particular patient, because I told you that you have been seeing this patient since 3 years. So at what stage of the disease would you ideally have referred this patient for transplantation?
See, ideally the discussion should be, when the patient was FVC was already declining, when it was already diagnosed like a UIP pattern, that time the discussion should have been started, at the time of the diagnosis of the disease. And of course, with the follow-up consultation, we can re-emphasize the patient that transplant is not something which is like an immediate surgery. It is basically just to start evaluating the patient early and start the optimization process, So if I delay, if I wait for the further delay, I'm actually losing the window for the successful listing.
Perfect.
Right? So what is the age of the patient, Kapil?
70. He's 70 now. So obviously 3 years back, he was 67.
Right. So that probably would be a hitch, from the transplant surgeons, that I'm not sure. But apart from that, if it was a young patient and if the transplant surgeon is ready, then I would definitely refer this patient early on.
Okay, thank you so much, Indu, because you mentioned about the age, and we are going to discuss this age particularly after some time. I will now start with Dr. Vijil Rahulan, sir. Vijil, sir, suppose Indu has called you and she's told you this much information. Are you happy with this much information, or what exactly are your thought process when you get such a referral?
Thanks, Kapil and CCI for having me, and greetings from Hyderabad, KIMS Heart and Lung Transplant Program. So basically, whenever a patient is referred, we would like to get as early as possible. We would want to know what was his progression, especially from ILD standpoint, and what is the criteria as per the PFTs. That is one thing.
Correct.
But this patient is fitting that criteria, but there are other issues like age is one, he has got comorbidities. So I would like to have definitely a history of what has happened and what is his status. We need more information in those things. I'm not saying, so if you look at the literature, overall worldwide, the patients, the recipients are getting more older. And initially in the guidelines, age was a factor, like 65. More than that was a high risk category. But in the latest guideline, it is 70. And this is not surprising because in the West, almost 30% of the patients are more than 65 who receive transplant. So once the age is more than 65 or even 70, then you have to individualize the patients and carefully select the patients. So I would definitely want to know about the status, how functional is he, what is his, whether he's frail, or whether how is his emotional or cognitive stability, and also is all the comorbidities, whether he's a smoker, whether he's how is his coronary disease, how is his creatinine. So these all needs to be carefully evaluated, and then we can, of course, go forward for listing him if we feel that he's a good
Okay.
candidate. But
But Vijil sir, I've got
age per se is not alone
okay.
is not a contraindication.
But Vijil sir, I've got a question over here. All these emotional things and all of this, would you rely on a history which your referring pulmonologist is giving to you, or would you get the patient? Would you see them yourselves and you take your own decision?
Yes, it is. History helps, but we have a multidisciplinary evaluation which happens on all the patient has been referred. There
Okay.
are psychiatrists in the setup, psychologists, psychiatrists, nutritional, and all the people evaluate these patients thoroughly, and then we proceed.
Okay. So from one transplant pulmonologist, I'll go to the other. I like to get Dr. Tapaswi in on the discussion. Tapaswi, I'll tell you one problem which I have spoken to a lot of referring pulmonologists. I'm sure Indu will agree with me on this. There is always a gap. A lot of pulmonologists have told me that whatever patient we refer to the transplant team, you always go ahead and do the transplant. You'll never say no. So is this a correct statement, or is this something to be taken in a more comical sense? And in this particular case, when will you, as a transplant pulmonologist, say, no, I am not going to go ahead with the transplant?
I need. Oh, sorry, it's for Tapaswi.
Tapaswi.
Thank you, Dr. Kapil. Thank you, Mankind, for having me here. So that's a very valid point you brought up, Dr. Kapil, that whenever a patient is referred to a transplant team, we go ahead and do the transplant. It is probably because most of the patients who come to us are actually candidates for transplant, who actually convert from a pulmonologist to a transplant pulmonologist. They understand, they read up, and they are actual candidates. It's not like, and sometimes when they ask for a transplant, there are times when Dr. Vijil sir would agree. There are times when we have refused a transplant also collectively together, especially when the patients have had neurological issues.
Okay.
Like infarcts, and they're not mobile. So that is the time we have refused a transplant. And of course, malignancies. Pre-transplant PET scan has become a compulsory thing nowadays. So any malignancy we refuse. And of course, this acute renal failure, acute liver failure, all the contraindications which you have already listed in your talk just now, we would definitely consider that. There have been times when we have refused a transplant,
right,
especially for malignancies and neurological deficits. And
And I completely second what you're saying, because as Dr. Vijil also mentioned, nowadays we are seeing that patients are older and older and older. So, there might be some latent hidden malignancy which we don't know. Absolutely. Only after a detailed evaluation like a PET scan, like you mentioned, we will elicit them. Indu, you've got a question. Please go ahead.
Yeah, like you were just mentioning about the malignancy contraindication. So let's say if the malignancy happened 10 years back and the surgery was done, chemoradio was done, PET CT was okay after 2 years.
Okay.
is that a candidate for transplant? Like
What
after, let's say, 10 years,
What malignancy are we talking about?
let's say GI malignancy.
Okay. Anyone, Vijil sir?
After
Jnanesh sir?
10 years, the patient came with ILD, and now the patient is eligible for, is the patient eligible for transplant?
Anyone can answer that.
Yeah, of course.
Yeah, go ahead.
Yeah, Vijay,
Sir,
go ahead.
So, any malignancy which is in remission for at least 5 years, and in some cases 3 years. So, if they are in remission, I don't see any. We will need clearance from oncology, and we will proceed with transplant. The recommendation is a little bit different in other. There is you can read up the document, but in general, if you see 3 to 5 years on remission, should not be a problem. Basically.
Okay. Thank
Indu,
you.
like Vijil sir mentioned, there is a wonderful document in American Society of Transplantation, AST. It's got a wonderful position paper. So different organs, they need different age groups for clearance. So something which will be 3 years cancer-free, you can go ahead. Something which is 5 years cancer-free, you can do it. So it's a wonderful paper.
But majorly 5 years disease-free should
More
be
than enough. Yeah, 5 years.
Okay, great.
So Jnanesh
And the
sir,
urgency for transplant.
sorry?
And the urgency for transplant in these patients. Probably we'll have to step back on stringent rules like Dr. Kapil and Vijay sir would have seen. There are cases in certain periods of time when you have to take a decision for the patient. He probably loses life unless you go ahead with a transplant.
Correct. Now, I would like to get Jnanesh sir in on the discussion. Jnanesh sir, as you can see, there is so much of discussion being done on age and, so many things. Even Vijil mentioned, even Indu did mention that, okay, age is probably a plus minus thing. Now, I would like to ask you, is age really a plus minus thing when we think of referral for lung transplantation, or do you think age is only in a state of mind?
Age is, Kapil, not a definite criteria for turning down a patient for lung transplant. In fact, if you look up the literature, we have published operating on an 81-year-old gentleman who was chronologically 81, but physiologically and biologically he was in good shape, highly motivated, and had a single organ disease. So we did go ahead at 81, and it is published in Annals of Thoracic Surgery. In fact, I was going to put it on the group just now. I will send that paper as soon as we finish the seminar on our group.
Probably we need
Sorry, go ahead.
Please go ahead. We need to take the frailty index into consideration probably before going ahead and branding this age is not fit. UK, they have this frailty score continuously doing the rounds. So probably that would help rather than going by age as a number.
Okay.
Yeah.
But all I'm saying is that in this case, we are discussing about a 70-year-old, and it is so heartening to know that Dr. Jnanesh sir has operated someone who's 81. So definitely, I think age is not the only criteria. You've got a lot of things, and as Tapaswi has mentioned, even frailty is something which we need to consider.
Plus, we don't have his echo report, and we don't have his coronary angiography, whether his LAD stent is patent or not.
Correct.
And we would like to look at his echo also, whether his EF is normal, whether he's got pulmonary hypertension. Correct. Does he have evidence of right ventricular failure?
Correct.
What is his BMI? So once we have all these information, whether his carotids are free from, because atherosclerosis, as you know, is a generalized disease. So if he has got ischemic heart disease, it's possible that he has carotid artery disease and peripheral vascular disease. So all these factors will be considered before we decide to list him for a safe lung transplant.
Perfect. Sir, what you mentioned is obviously a whole component of something that we call as a pre-transplant workup. So there are so many things which we see, as you and Dr. Vijil sir have rightfully mentioned. Indu, please go ahead with your question to Jnanesh sir.
So sir just mentioned about pulmonary hypertension, that we have not done a right heart cath, or we don't know that. Sir, I would like to just ask you, let's say if the patient is a high-risk patient, functional class 3 or 4, with a high pH, confirmed by a right heart cath, would this patient still, because he's 70 years, Would you think otherwise?
Indu, can I please interrupt over here? See, we are going to have a discussion on cardiac status in some time. So I think
Sure.
during that time we will
Okay,
this question.
sure.
Okay. So definitely cardiac status is important, but we'll come back to that point.
Yeah, there's one more comment I want to make, Kapil.
Yes.
So one of the things you asked is whether early referral. So a referral doesn't mean that we immediately do for transplant.
Correct, sir.
So one of the things I would like to tell the referring physician is that if you refer early, it's not like that we will take him directly for surgery. You will evaluate him, and if we feel that he's early, he can wait. Definitely, we will call him back in 3 months, 6 months. It's so it's not true that whenever you refer, you go for a transplant. So
Correct.
if we feel it's early, we definitely will wait and see whether he qualifies at some point or some complication happens or whatever. We may list him, but he will be inactive on the list. And then if anything change with the patient, because the listing in India is a little bit different compared to the West,
Correct.
because it is still the allocation is based on seniority. So he may not be active, but we will do the workup and then monitor him clinically, basically.
Perfect. Thank you so much, sir, for making this point, because a lot of referring pulmonologists do not know this, that allocation in our country works sort of differently. It's almost like a first come first serve basis. Okay, so we get a lot of these questions, and that is why I exactly wanted to ask this. Because everyone thinks that we send a patient and y'all don't see anything in your straight away list. But unfortunately, that is not the reality. The reality is slightly different. Thank you so much for clarifying that. We'll just move on.
Kapil, can I make one more
Yes.
with reference to the same thing about listing?
Correct.
One very senior pulmonologist referred to me 3 patients in 1 month. And by the time we finished workup, uh, all of them became so sick that either they were not transplantable, or some of them, all 3 of them, in short, didn't make it to the list and they died soon after. So when this pulmonologist was conveyed this information about the update on his patients, he made a change. He sent one comment to me: I am sending these patients too late. So in the subsequent patients, he started sending patients with the instruction that this is time you go and start learning about lung transplant. This is one suggestion I have for the referring pulmonologists. If they are not very sure about the referral criteria, you can use this sentence: this is time to go and learn about lung transplantation. So you go to a transplant pulmonologist or a transplant surgeon, whoever.
Perfect. Point very well taken, sir. And I hope that a lot of people have logged in and are listening to this story. I would just like to mention that you are really lucky. In 1 month, you got 3 referrals. The others cannot say the same, about themselves. But we'll just move on with the discussion. I would like to get Dr. Animesh Jain on the discussion. Animesh bhai, you have been listening very patiently to, this entire age thing and referral thing. Now, you are in community medicine. Now, from a community medicine point of view, if you could tell me what steps you would take to encourage lung transplant referrals.
Thank you, Dr. Kapil. Am I audible?
Yes, you are audible.
Okay, great. So, see, I think one of the challenges we face, or rather 2 challenges I would say, is one is there is very low or poor awareness in general. I'm not talking about the metro cities, the big cities, or the affluent classes or whatever. But generally, if you see, and the kind of population that we have a very poor awareness. Along with that comes so many other facilitatory factors, if I can put them like that. That is, one is, post the procedure, the support system and other things like that. And the second thing is, of course, the financial aspect. Now, having said that, these are the challenges that we need to think of and overcome. Now, for the first thing, that awareness level, I think it's time that we start utilizing different strategies, including the mass media and the social media, because social media is a very powerful tool. So I think that's something which can be harnessed. And we can even bring in like success stories of patients, like what has started happening in probably, you can see the tobacco and cancer kind of a thing. Even when you go to movie theater, you see things like, a person talking about, or even a positive thing where person who's had a lung transplantation talks about it, and then people who have been donor families, they are supported or they are celebrated or they are recognized, something like that, because that will encourage people. Otherwise what happens is people are not really coming forth with it, and there is always a stigma kind of thing that, and then people have misconception. Or what, especially if I'm talking about a live donor and even a part of it or whatever, they'll say that, oh, how can I just donate or something. So it becomes a kind of a challenge. So I think that's something which has to be overcome. And
Perfect.
as I said, financial, I think those kind of things have to be looked at. And even the government schemes, a lot of things probably can take it into its ambit and do something about it. So these are some of the like very quick thoughts on that.
Got it. Okay. Sir, points very well taken, because especially your point about social media, because now social media is the platform. A lot of awareness needs to happen on social media, which is why I tell everyone, please subscribe to Detox with Dr. Kapil, lekin koi karta nahi hai. But, on a more serious note, I just want to get Vijil sir and Tapaswi, both of you all into the discussion. I think Dr. Chennamchetty Garu will take some more time. I want to ask you all about a gray area which I personally feel in one of the contraindication points, and that is a poor rehab potential in the post-transplantation period. Okay. Now, usually we see these advanced ILD patients, they are too sick, they are frail, their BMIs are decreasing, they can hardly move around in the house. When both of you see such a referral, do you think, how will you stratify them as a poor rehab potential post transplantation? What do you mean by that?
So that's not a very deep, easy question to answer, because there are two aspects to it. One is that their poor rehab potential is directly related to their lung disease, basically.
Correct.
So we can always say, if we change the lung, he will have a good outcome, with reference to rehab. That is the overall context, how it is going to be. But still, we have to evaluate so many other things, in the sense, one of the way we do it as a pre-operative evaluation is to see, assess his correct functional status now. And the easy tests like 6-minute walk test, or a frailty evaluation, or a short physical SPPB, or even a hand grip test. So there are a lot of tools to assess objectively how rehabable, or what is his physical status, what is his potential to improve. But you should always keep in mind, if his frailty is directly related to lung disease, there is always a good chance, even though the patient may look very thin and wasted, there is always a chance he will improve after transplant, if there is a good motivation and willingness to participate in the rehab, and a good social support. But if there is a lot of weight loss, he's bedridden, not much social support, no motivation, elderly, then then it becomes difficult.
Correct. Tapaswi, you agree with Vijil, boss, or you've got something else to
I
offer?
absolutely agree with sir, and I have something to add. See, sometimes these critical illness myopathies, which come because of long-term ECMO or long-term ventilator support, or they're bedridden because of ILDs. So that very thing becomes an indication for a transplant. So if they have to get out of ECMO or get out of that, becomes an indication for transplant. So it could be actually the cure to what we are calling a contraindication. Apart from that, if there is an progressive neuromuscular disease, which is not going to revert back, then of course it's going to be a contraindication. And sometimes we see these patients with stroke, infarct, embolus, and so on and so forth. Probably in them, we should look at their neurological improvement, balance it out with the oxygen requirement, how bad they are in terms of ILD and how bad they are in terms of the neurological disease. So we balance it out and then go ahead with a transplant. So,
but I hope both of you do agree with me that this is a sort of a gray area. It's
absolutely
not a simple, straightforward thing, and it needs a lot of an MDT approach. Okay, so I'll get Indu in on the discussion. Indu, now in your first answer, I remember you mentioning about the nutritional status. You would like to optimize a patient nutritionally. In this particular case, what do you mean by optimal nutritional support? And do you take charge and do this completely on your own, or do you get someone else's, a dietitian's help, support, and all of that? What is your thought process?
So basically, Kapil, optimizing nutrition is integral for transplant readiness. We all know that, right? And most of our ILD patients are sarcopenic and they have a less muscle mass. It's not preserved well. So usually what I do is I take in the clinical dietitian early on in the management part, and we set the targets, calorie targets around 30 to 35 kilocalories per kg per day, with a protein target of around 1.2 to 1.5 grams per day, and even higher if there is a muscle loss. So I think this part is very important. The goal is basically to maintain the BMI of between 20 to 25. Okay, so basically a well-nourished patient does very well post-transplant. That's what I mean by optimizing the nutrition. And we have seen patients do well. Kapil, you're freeze. Okay, I think Kapil got freezed.
Hello.
So,
I'm back. I'm so sorry. There was just some technical glitch. So nutrition, yes, I agree with you. Indu, it is completely, very, very essential. Even from a transplant point of view, I'm sure Jnanesh sir and, Dr. Vijil and Tapaswi will agree. How much do you all rely on the referring pulmonologist to take over the nutrition optimization? How much do you all do it? Anyone can answer.
Kapil, we optimize the protein. Now, I want to just go back to the comments that the topic that about which is the 13th point in the absolute contraindication in that document or consensus document which you showed, which reads that limited functional status, non-ambulatory patient with poor potential for lung is an absolute contraindication
Correct.
for lung transplantation. So, as Vijil has pointed out, that we do a number of frailty tests. One of the tests I want to show is very simple. You can do it in your clinic, and that is to keep your hands up. As you know, we have done it, and to ask the patient to get up from the chair.
Correct.
If he can do that easily, like that, then that means you have got good proximal muscle strength, which means that the quadriceps are in good shape. And there is some conversation going on between accessory respiratory muscles and quadriceps muscles, which I don't think scientifically we have understood it, but we have seen it in clinical practice. Like this thing. This is just one comment I wanted to add.
Okay.
The nutritional status, of course, we have take the help of a dietitian, and we ensure that they get at least 1.2 grams per kilogram of protein and adequate calories. And we give a period that their BMI should go above 17 or at least reach 17.
Okay.
If after all attempts, the patient's BMI is not reaching 17 and the patient is clinically deteriorating, then we go ahead and do what Vijil and Tapaswi said, that you go ahead and transplant, because that will help the patient recover his BMI. Of course, BMI is a very poor surrogate for body composition, but that's the best we have right now.
Got it. Okay. Dr. Vijil sir, now I would again like to point this question to you. There was a discussion about this, but now it's a more directed towards you. In the history, I mentioned that one of the comorbidities of the patient was ischemic heart disease, and it's just a loose thing that PTCA to LAD done. Now, see, I'll give you different scenarios. Let's say first scenario is right now, the ejection fraction after the IHT episode is 55%. What will be your approach?
Yeah, so this is one of the high risk or higher risk category, the patients with coronary artery disease, and this needs to be very carefully evaluated. All patients will get an angiogram to carefully assess the coronary issues, as well as an echo to assess pulmonary hypertension, the RV function, LV function, all of these things. So if there is coronary artery disease with a normal EF, that is not at all a contraindication. I don't think it's even a relative contraindication as such, because we can have several options for these. You can fix them with a PTCA, then go for transplant, or we can do transplant with CABG at the same time. However, if the EF is low, then it would mean we would need to have a more thorough discussion and more, because the risk is going to be much more higher than with a normal EF. So if, as you said, if EF is good and if coronary artery can be fixed, we will repeat the angio, see what's the status. We routinely do PTCA if the patient can wait, and then put on double antiplatelet agents, and 6 to 8 weeks later we go for transfer. We activate the patient. But otherwise, if patient is sick, can't wait for 6 to 8 weeks, we do transplant with CABG in the same setting.
Got it. I was about to ask you this, that when you're routinely evaluating a patient, all of us do an angiogram. If suppose it picks up a 99% blockage or something, how will you manage?
Yeah.
So, like you properly mentioned, if suppose we can wait, you obviously will go ahead with the stenting, wait for at least 8 to 12 weeks on dual antiplatelet and then transplant. There was, sir, also, if I'm not mistaken, I think Indu previously was asking this question that, we don't have the echo right now, but suppose the echo does show, apart from the IHD, that this patient is also having pulmonary hypertension. How will the thought process of the transplant team change in such a matter?
So most patients with ILD will have some degree of pulmonary hypertension in India when they are referred, because we don't see patients. Unfortunately, the reality of situation is that they get referred when they have more advanced disease, and pulmonary hypertension invariably happens in ILD patients. Correct. So that is not a contraindication in any case. We are worried more about how the right ventricle is, rather than just the number, the pulmonary hypertension itself. Because there are several layers to this. There are some programs who do off pump method, means they will do without the cardiopulmonary bypass. In that case, pulmonary hypertension can have an additional risk there. But now more and more programs have gone to doing transplant on an ECMO, which is a VA ECMO. These things can be more safely managed, especially even if the pulmonary hypertension is more severe. Of course, the transplant program experience when they induce the patient is important, because there may be hypotension events and other things. But pulmonary hypertension per se is not a problem. But if the RV is dilated because of that, then we need further tests, like even a cardiac MRI. You have to look at how thinned out the RV is, how is the RV ejection fraction, what is the volume, can the RV handle the surgery. All these things has to be assessed.
Okay, got it. Tapaswi, I'd like to get you in on the discussion. Now, there are two things which I would like to ask you. First is, what is your understanding of oxygen optimization? Because, usually you will see patients who are referred from a pulmonologist, they will mention that, okay, oxygen has to be used at, let's say, 2 liters per minute. Are you happy with that, or do you feel you per se also have to take an active role in oxygen optimization?
Lovely question, Kapil. Actually, oxygen optimization, for me, I feel it's like hitting a moving target. So we need to have our tools. Patient attender, he should be having a pulse oximeter, and we should probably keep doing this repeated ABG, which we have to keep the patient counseled for. So probably we should go for most minimal invasive oxygen delivery system, so that the patient complies to that and not stops taking oxygen. And he should be mobile. Most of the time, what we have to concentrate is on the patient being mobile with oxygen. So portable oxygen delivery systems, which we have to advocate, which probably weren't given to the patient before. So I've had a lot of patients who think it's only the cylinder. Correct. Which will help him. So they're most of the times our ILD patients, they're actively working as chefs, as moving business people. So portable oxygen delivery systems have to be advocated. This helps their psychological well-being as well. And of course, it will help in keeping the right heart fit as well if we optimize oxygen delivery.
Correct.
So yeah, we do have to take it into our hands and also talk to the referring pulmonologist and keep them in the loop about how we would want our patients to be optimized on oxygen. So our target would probably be 92 to 95. That is more than enough.
Got it. Jnanesh,
And keep the carbon dioxide in check, especially when the patient is a COPD patient.
Got it. Okay. Jnanesh sir, now, I'll tell you one thing. A lot of pulmonologists who refer to us think that the only transplantation which is done is either a double lung or a heart lung. So the concept of a single lung transplant is somehow, a lot of people say that it is very inferior, it is not good, but as a surgeon, this patient, 70-year-old, IHD, I am not, he's already on LTOT, 4 to 5 liters and all. When do you surgically decide about a single lung or a double lung, and how do you decide that?
So, Kapil, if you presume that he has got pulmonary hypertension, the evolution, if you look at lung transplantation, when I began my fellowship in 2005, at that time for ILD, the patients were being operated, only single lung was being done. Correct. Even if the patient had PH, we used to choose a bigger lung. And we used to choose the lung. But as double lung started coming for ILD patients, three patients were published by Cleveland Clinic. And after that, slowly, all the other programs started doing double lung. Today, most of the programs will first think for pulmonary hypertension with ILD to be a double lung transplant. Now, in this particular patient, suppose he is 70 years old, has got patent LAD, the stent is patent, the LV ejection fraction is 55%, then what I would think would be that we should try to do a double lung transplant, but with his other comorbid condition and his frailty we don't know, then we would even do a single lung transplant. We would do a VQ scan, because I like to do this surgery off pump. If the pulmonary artery pressure on starting 0.025 of milrinone and nitric oxide of 40 parts per million, if the PA pressure comes down below 50, then I would like to do this surgery off pump.
Okay.
If the patient's PA pressure remains above 50 or nearing 50, then like Vijil said, we would like to do it on ECMO, VA ECMO. That would stabilize the patient. Now, if suppose on opening the chest and you look at the pulmonary artery, and the size of the pulmonary artery is twice that of aorta, that means you need to decompress the pulmonary artery. Then you would not use ECMO, you would use cardiopulmonary bypass.
Okay.
To do, because the difference between ECMO and cardiopulmonary bypass is that you cannot decompress on ECMO. ECMO is just like beating heart, except that it is safe for the patient, a little safe.
So I think a lot of...
Now, if the patient has got a VQ scan, I would think that the patient is blessed if his left side has got lower perfusion, because there I can put in a bigger lung on the left side very easily, because it will push very easily without doing any trimming or anything. And somehow the left side chest cavity accommodates a larger lung better than on the right side.
Okay.
So the left lung, single lung transplant, if the perfusion of the left can be done off pump if his PA pressures are less than 50.
Got it. So I hope a lot of listeners and everyone who's logged in, these are, I think, surgical pearls, which, sir is mentioning, it's something very new and very novel for all of us. So thank you so much, sir, for your insights and for your practical experiences and your expertise. Animesh Bhai, again, I would like to ask you, according to you, what do you feel in community settings are the common barriers because of which the transplantation is completely delayed?
I think we don't have a, see, other than the awareness that I already mentioned. And so I also feel that probably we don't have support systems, and also there's no kind of a, I mean, if I can say that national registry or something, if say I want to go and register for it, there are registries for this, but lung, I'm not really sure if I have come across something very particularly. And
Okay.
even for a person who wants to look for, so that is another thing which, and then there are psychosocial and then also kind of, factors which probably let people think that, okay, why should I, or I should not, why should I do that? So those kind of things are there. Other than that, I also feel sometimes it becomes challenging when we have people with, see, we have those chronic diseases, especially I'm talking about non-communicable diseases.
Hmm.
These could be sometimes challenges. And obesity is another challenge I can look at. So these are some of the challenges which are there, which probably make it more kind of challenging. Though people may think of, but then they'll say that, okay, I'm already having this kind of a comorbid condition, or I'm having something. Why should I like compromise on my functionality by doing this? So these are some of the other things as well.
Got it.
I think these are some of the barriers which will be, and of course, I've already mentioned cost. I think that is one of the biggest challenges.
Hmm.
I'm talking especially like, if you're thinking of a person from even a middle class or a lower middle class thinking of it, most of these centers, the other thing is accessibility. When we talk of public health, we look at accessibility and availability. Accessibility. We have centers and we have a group of hospitals which are spread across in some cities. But then what about the second tier and third tier cities? It's not as easy. So all those things make it, I think, a little difficult. Probably we'll have to think of something which can make access better, availability better, and awareness. So these are some
Got,
of the things I would.
got it. Thank you so much for
I
your
would like to
input.
add one thing, Kapil.
Yes.
Very quickly, in India, I think the biggest barrier is lack of organ donations. I think we have recipients, we have affordable recipients. Even
Absolutely.
though the population wise, if you see it may be less, but the population is so much that there are enough affordable patients. But the organ donations is a major. That's the foundation. It's a cadaveric program. It's not a living like a liver or kidney or something. So organ donation has to be increased by government or mass media or awareness or influencers, so that at least the once the donations improve automatically, I think the numbers should also improve. So that's something I would like to point out.
Vijil sir, you are
Absolutely.
making all of us jealous.
Absolutely agree.
First of all, you are
Yes,
sitting in
absolutely
Telangana
agree.
with so much of organ donation, and all of us are not so blessed. So you are making us jealous. First of all, you and Tapaswi, you all are at a natural advantage. Let us not even talk about Tamil Nadu, but yes, point well taken. And Animesh, by one point I would like to mention, you mentioned about the cost. Yes, I also do believe that cost is a huge barrier, and for that purpose, we are planning an exclusive webinar about the financial aspect of lung transplantation. It has never been done before, but I think that's something which all of us should look forward to. So we will definitely plan
Great.
that. We will take your
A
point.
follow-up webinar.
Yes,
Yes.
forward. Okay, now I would just like to come to the next part of the discussion where we've got this patient, a 70-year-old guy, IPF. This is Indu's patient. Unfortunately, one day she receives a call. The patient has come to the casualty. There is some, hypoxic patient. Now they are just 82, 83% on 6 to 8 liters. X-ray showing increased opacities. The CT also shows ground glass opacity. So basically, Indu has diagnosed this patient right now as acute exacerbation of IPF. Okay, so infection has been ruled out, everything has been ruled out. Let's say we are dealing with AEIPF. Indu, I would like to ask two things to you. At this particular age, at this particular stage of the disease, what is your thought process with regards to mechanical ventilation, which is the first, and second, with regards to ECMO?
So I think this is a great question, first thing. And we are not well equipped with the communication about the advanced lung disease. I mean, in our medical studies, we are not trained enough how to have a communication, doctor-patient communication. So when we are talking about mechanical ventilation, it should only be given when there is a clear role and it's a reversible disease. So IPF being a irreversible disease and a progressive disease, I would not actually want the patient to be put on mechanical ventilator. But if I feel the patient will come out, even if I'm putting on the ventilator, then I would like to wean him off very, very early so that he doesn't get dependent on the ventilator. Yeah, at 70, I would not like him to struggle on the ventilator for too long. So that communication will happen before the acute exacerbation happens.
Yes.
So, and with the family all together before this episode happens. And the second part of your question about the ECMO, again, ECMO is not a reflex decision. It should be a multidisciplinary decision, goal-directed decision. So as you said, this patient actually had an acute exacerbation, rapidly declined with increased opacities on the X-ray. So these kind of situations we would face and we are facing. And that's why ECMO, as I said, it should only be given to the patient. The option should only be given to the patient when it's like a bridge to either a recovery or bridge to lung transplant. Otherwise, if there is no exit strategy, then it is futile and actually ethically inappropriate. So because it's very costly also, and it can lead to side effects like infection and other things. So it's not easy. I mean, the decision. So the discussion should happen and documentation of every discussion should be made. We should discuss about the finances of the ECMO with the patient. It's around, I think, 3 lakhs per week with the lung transplant cost of, let's say, whatever, it's around 30 lakhs or something. So I think the documentation of all these things should be happened. And finally, I would say that ECMO combines everything, the clinical urgency of the situation. It combines counseling with the family. It also combines the cost factor. So I think combining everything, when the decision is taken, all the members of the family should immediately understand why the decision is taken. So,
Perfect.
yeah.
Indu, completely agree with you, and I love the fact that you mentioned that actually these are things which the communication has to start much before the acute
Crisis happens. Yeah.
So that's a perfect takeaway from what you've mentioned. We've just been joined by Dr. Vijay Kumar Chennamchetty Garu. Garu, welcome to the panel discussion. We're just discussing about ECMO and lung transplantation, and our elderly IPF has had an acute exacerbation. Vijil sir, I would like to ask you, in what situations will you consider this ECMO to lung transplantation? What exactly are the success rates of a patient who has been bridged in your center, let's say?
So there's a lot of things in it. If there is a patient whom we have evaluated and is waiting for lung transplant, and then he deteriorates, goes on ECMO, that's a different scenario. Then we go all out for ECMO because we have already evaluated him. And in that case, ECMO is important in the sense we have to maintain the single organ issue, and ECMO is the best way to do it. Unfortunately, mechanical ventilator in these IPF or ILD patients will not be able to do it, and they very quickly develop multi-organ failure and then either die or they are not a candidate for transplant. So ECMO is timely ECMO insertion is important in these patients to maintain all other organ functions. So with our we have done several of these patients and they have very good success rate. It is probably close to 60 to 70%. In on other ways, these patients will die basically.
Okay.
However, if the patient is 70 years, we have not evaluated, like this patient, there is a history of, say, coronary disease, we don't know. Then offering a elderly patient ECMO without properly evaluating, I will not do that actually, because the younger the patient, say at least less than 50 or 55, the much better success for ECMO. The older the patient, more complications. Probably that will be futile, as the previous speaker mentioned. I don't think unless a younger patient and unless we have evaluated them before, on waiting list they deteriorate. I don't think ECMO is a good option. But for others, ECMO is the only option, as a bridge of transplant with any success.
But again, Vijil sir, again, I want to ask you this question. See, as far as ECMO and bridging is concerned, one of the most common referrals to you basically will be ARDS.
Yeah.
But if suppose sepsis is the reason for ARDS, what will be your thought process? Will you consider this patient for transplant? Will you not consider? Will you wait for the acute episode to die down? What is the period that you are willing to wait before you come on this decision?
So there are very clear-cut guidelines for the option of lung transplant for non-resolving ARDS, basically.
Okay.
So the recommendation is to wait enough time for the lung to heal on ECMO, and only then give this option of lung transplant. The time frame is at least around 6 weeks. In various papers you can say 4 to 6 weeks, but you need to give enough time for the native lung to heal, either on vent or ECMO, to consider this option. So increasingly ARDS is increased a referral pattern, which is, especially after COVID, there'll be more and more referrals in this subset of patients. But the general principle is that you have to give enough time, and you have to assess the whether it is a irreversible damage to the lung has happened or not, either by CT scans or by looking at the ventilator, whether any tidal volume is getting generated, or any complications like big cysts are forming, pneumothorax is happening, or any other issues like bleeding. So these things has to be evaluated for any patients on ARDS subset before considering transplantation. Sepsis per se, if it is limited to the lung, if you think lung is the source of sepsis, that's not a contraindication. We will remove the lung, put a new lung, he'll do mostly okay. But if there's an active blood infection going on or any other source is there, then that becomes a challenge.
Okay, got it. Tapaswi, I'd like to get you in on the discussion. Obviously, Vijil sir did start about bleeding and all of this, but I want to ask you that in an exclusive lung transplant and an ECMO center, how do you manage these patients on ECMO? What is it that you do differently, which, let's say, probably a normal ICU will not?
Kapil, like we have already discussed, road to transplant patient should be ambulatory. So as transplant pulmonologists, we want to keep that ECMO patient also ambulatory,
Okay.
eating. So what do we do for this? Try and put him on an awake ECMO. Extubate him or her onto HFNC or NIV so that we'll be able to ambulate them better, and they should be able to communicate, talk to us. So, or if you're not able to extubate onto NIV or HFNC, go ahead and do a tracheostomy at least as soon as possible. So that way you can ambulate the patient better. Apart from that, we would try to go down on the transfusions so that you're not sensitizing the patient. Just maintain at least 7 to 8. You tend to have anemia when the patient is on ECMO. So try and do lesser number of transfusions. So apart from that, yeah, sepsis, like sir already mentioned, we have to keep doing repeated blood counts, LFTs, RFTs, and check for sepsis component, because it shouldn't put the patient back off the list, since sepsis is very scary for us to handle unless the nidus is the lung. So keep looking for infections, keep your patient fit until we can find a lung to transplant for him on.
Okay. Now, Jnanesh, you are the program director. You have managed so many centers, okay, not only from a surgery point of view, but from an overall program point of view. Now, you obviously would have faced these situations very often, where you are in one particular city, there is a patient, let's say in some other different city, patient has to be put on ECMO, airlifted, so many things have to be done. How do you ensure the logistics and the financial implications in this entire process?
Well, Kapil, the question is very good, and it's a tough question because all the points that both these Tapaswi and Vijil have mentioned, those are all vital: ambulation and prevention of infection. Now, there are two scenarios. One is that the patient has, say, I am in Yashoda Hospital and in Global Hospital in Mumbai, the patient has already been put on ECMO by the surgeon over there. Now, the team from Yashoda Hospital goes to, and then we transfer the patient to Yashoda Hospital. So that would be one scenario. The other scenario is that the patient is very sick on ventilator, and we go there and we put the patient on ECMO and then transfer him.
Okay.
So these are two different scenarios. Of course, these transfers are very, very high risk. We have to make sure that the cannulas are well fixed, that there is a whole team, there is an intensivist, there is a physiotherapist, there is a group of people, our perfusionist, everybody goes together and then they shift the patient from, say, Bombay or from Vijayawada or to Hyderabad. So these are very tricky and precarious situations.
Okay.
So we have done that many times, and then
okay, please go ahead, sir.
Yeah. No, then we have to, of course, do what Vijil and all, what Tapaswi said, that you have to gradually get them mobilized, try to extubate them, and be an awake intubation, awake this thing. Sometimes we have also shifted a patient on a double lumen ECMO so that we can ambulate him better, because the single most important factor is for an excellent outcome is that if the patient can be ambulated. Now there are recent publications also where with femoral venous cannula VV ECMO as well as VA ECMO, these patients can be actually ambulated. There are several publications which can be done safely, and there is a protocol which we can follow for seeing that there is no catastrophic event during ambulation.
Okay, got it. Understood. So you mentioned in between all the different specialists, now your intensivist, your physiotherapist, and all of them should be available. As long as there's no you don't disturb us in the middle of the night. We are very happy, sir, with you handling the entire process.
Yeah, initially I used to go there myself. Yeah.
Acha.
Yeah, one comment, Kapil. So all
Vijay,
these.
Sir, please don't say that you as a pulmonologist also go on, sir. Don't put us in.
No. One comment I want to make here is all the ECMO transfers would need an air ambulance. That is part of the cost.
Correct.
Absolutely.
So, yeah. So there are air ambulance companies who can be contacted. We have tie-ups with some, and the ambulance is stationed in Hyderabad. But the cost will depend upon where the aircraft is coming from. If it is in the city where the aircraft is stationed, the cost may be less. If it has to come from some other city, pick the patient, go to another city, cost will be more. So air ambulance is essential. If there are, and that adds to the cost as well.
Okay. So I think what we should do is not do all these webinars and open our own air ambulance company. Is that what you're mentioning, sir?
That's what
That's what pulmonologist has to do.
God, understood.
Actually, Shalini Nalwad is a doctor herself.
She's an emergency physician, sir.
Yeah. See, good. We get to learn so much from CCI webinars. That's good. Animesh bhai, I'll ask you one more question. What tools or protocols for screening patients with chronic lung diseases are available at a community level? Is there something of that sort? Is that something which you want, or you are quite okay with it not being present?
No, thank you for this question. To be very honest, I have not come across. Maybe I'm limited in my knowledge. Having said that, I think there are certain other things that can be looked at. One is, our country has a very different kind of a population and very different socio-economic dynamics. So we have very poor people, rich people. Then we also have people with morbidities. We also have smoking. We have obesity. We have undernutrition. So I think these are some of the things that I'm looking at as well.
Okay.
Because these could be relative, or these could be contraindications as well. So this should be definitely looked at, and this is not difficult. I mean, if I'm talking about taking a good history about smoking or any other chronic conditions and things like that, even for a physician to refer or not to refer can be done. Even when I'm looking at a BMI, it's a very simple thing. But other than that, a kind of a tool or a screening aid or something, I'm not aware of. maybe one of the other panelists or some of the other panelists may be knowing. But to my knowledge, I'm not aware of any particular tool which can look at specifically for lung,
Okay.
that is lung transplant and lung donation.
Okay. Got it. Okay, perfect. Now we'll come to the last part of this webinar, and I would like to get Dr. Vijay Kumar Chennamchetty Garu on the discussion. Sir, in your day-to-day practice, you will be seeing so many chronic lung diseases, so many patients. At what part and when exactly should a general pulmonologist at least breach the topic of lung transplantation? What is your thought process on that?
First of all, thank CCI for having me here, and apologies for joining late due to some technical reasons. I was held at an examination, okay, and the commute time from there to here is little longer, so stuck in traffic. Thank you, Kapil, for that wonderful discussion. I was listening to the discussion for the past close to 30 minutes, so absolutely enjoying. The biggest challenge, Kapil, in our day-to-day life is our patient behavior. What they do is, unless they come, they have an exacerbation, whether you label it is asthma, whether it is COPD or it is ILD. So the moment they have an exacerbation only, they will see you. That is the biggest challenge. So when they, otherwise, what will happen is, so in my opinion, there is always a scope that the moment you diagnose an advanced lung disease or probably a ILD, so in the discussion, okay, not to really stress, but again, give them a hint. Yes, if you don't manage yourself well, okay, you may end up in getting transplantation. So that's first thing. Probably I begin in my practice very early in the discussion. The moment I see a fibrosing ILD, or a patient who have an ILD with exacerbation, or patients whose saturation is dropping. Example, the moment they walk in, if you check pulse oximeter, the saturations are 90, 91, 92 kind of thing, but after probably a minute rest, their saturation is settling to 97, 98. These are the patients where we should start talking about transplant, and then more intensify the discussion once there is an evidence of progressive fibrosis or patient is requiring oxygen support for his day-to-day activities, and once he gets a cor pulmonale or a concomitant pulmonary hypertension, these are the patients. And whenever we are initiating, I ensure that the holistic assessment, like okay, whether this patient has got a very good financial support, family support, a lot of good friends who can help him, because ILD is one thing. The moment you write a ILD diagnosis or ESLD, end-stage lung disease, okay, lot of times they start to, feeling very low. So how to tell them, how to, we have to ensure that to let them know in a very, very positive note that they prepare for next many years, because these are the patients, they require a lot of empathy, and that's from my end.
Correct. Sir, but I've got a cross question to you. Now, you see so many patients every day. You are a master in communication. You've got a very pleasant and a very positive predisposition. When you do talk about lung transplantation for the first time to your patients, how do your patients take this up?
Yeah. See, what I'll do is, I'll not initiate this discussion in my regular busy outpatient flow.
Correct.
I'll call them, okay, my OPD today is going to finish by around 6:30, 7 p.m. So my request is, please come here along with your kith and kin and stay here from 6:30 onwards. The moment I finish my OPD, I'll talk to you.
Got it.
And then I'll plan it such a way that at least this discussion time is minimum 25 to 30 minutes. Okay. And many patients, okay, they'll go back with definitely a lot of take-home points. They'll say, okay, sir, let us discuss with our entire family. We'll come back to you. Many patients, they do, accept that transplantation is a viable and then possible mode of intervention in their lives. And then they are, at least they are receiving. But if you see 5 years back, pre-COVID data, okay, many people, they used to, get feared. So, and then pulmonologists per se, I just want to state a generalizing statement. I'm sorry if I'm wrong. Please correct me as well. So, majority of time, they fear to convey the message of patient may need transplant. They don't say it very confidently. Once any word you say without confidence, okay, it will not go into the minds of the patient, and naturally they'll get fear. And then pulmonologists generally, okay, they fear that they may lose the patient. It's not so. Okay, you should take them on your side by giving good enough time. Most of them, they will accept it.
Perfect. So thank you so much for telling us about your thought process. It's very refreshing to know how a general pulmonologist approaches this topic of lung transplantation, how much of a communication and all is required. One thing I would like to mention, sir, as long as you are referring to me, we are fine. Okay. Indu, I would like to get you in on this discussion. Now, see, now Dr. Chennamchetty sir has got a very individualized sort of an approach towards his patients, right? But end-stage lung disease, lung transplantation, these are sometimes medical legal issues. Counseling is very important. Sir has at least 20-25 minute session with the patients. But my question to you is, and you may differ from sir in your answer, how much of the responsibility of counseling should lie with you, and how much of responsibility should lie with the transplant center?
Sure. So great question. I think communication is a very essential topic, I feel. And a good transplant or a listing will only happen if the patient is referred and if the patient is referred on the right time. So I feel counseling plays a very, very important role. And I believe that the general pulmonologist carries the most crucial responsibility in counseling. The patient has trust on us. So the idea of transplant should start with us. The explaining the disease trajectory, prognosis, risk, and the timing should start with us, I believe. And, the counseling should definitely, can be taken forward to a transplant specialist when the patient is mentally prepared. We bridge in the transplant specialist and for the detailed logistics and other purposes, but we stay looped in for the reassurance and for the continuity part of it, So I think the counseling is completed by the transplant pulmonologist, but the foundation and the trust is built in our clinics. So I think it's a teamwork.
Correct.
Yeah.
Okay. Vijil sir, I would like to get you in on this discussion. Now, Jnanesh sir in one of his first answers mentioned that there are so many things which he would like to see and do in a patient. Okay, like right from your carotid Dopplers to your ultrasound abdomen to your right heart catheters, echo, CT. There are so many things which eventually all of us in our transplant center, we perform these tests. We call it as a pre-transplant evaluation. But my question to you is, when you've got a referral from a pulmonologist who, let's say, is not in your city, how much of this workup do you expect the referring pulmonologist to do, and how much do you do in your center? What is your approach?
So our approach is we try to do almost always the whole workup. Because we have a well-oiled machine. The workup is done in 5 days on the hospital as an inpatient. Because otherwise, there are some few tests which has to be interpreted by our team, especially the right heart study. It's not just the numbers. And there an esophageal or a gastric reflux evaluation. So these has to be done by a center who keeps on doing it to look at proper risk assessment. So we prefer to do most of the workup here. But in case other things like CT scans or some blood tests, probably we can get it done even by the referring physician. And then see specialized invasive tests should be done by the transplant center, because interpretation can vary from a center which is experienced versus somebody who's just doing run of the mill basically.
Got it. Understood. Okay. Now, Tapaswi, I would like to ask you, we have broached this topic, but I would like to ask you specifically. Again, suppose there's a patient who's in some other city being referred to you. How do you in your center overcome these geographical barriers? Remember, India is a diverse country. People come from different backgrounds. Their food habits is very different. In our country, from a patient's perspective, food is very important. As all of us have seen, when patients come from different cities, how do you overcome all these barriers? And in every case, do you want the patient and the relatives to completely shift to your city when they are waiting for a transplant, or you are still a bit lenient?
So when it comes to moving to the city, it so happens that these transplant patients are very emotionally charged also. So they attach to one particular transplant pulmonologist or to the surgeon who is going to operate them, and they choose a center. In fact, they have choice right now. So when they choose this particular center, it is mandatory they shift to the transplant center, the city where the transplant center is situated, so that the transplant procedure is easier, because like coordinating between the donor and the recipient is very difficult if they're elsewhere. Especially we have patients coming from Delhi, Assam, in fact. So it's very difficult to bring them in when we have a donor ready, especially if there is an in-city donor. Definitely we need to keep the patient here pre-transplant and post-transplant at least for 2 months. But luckily, when it comes to transplant OPDs and post-transplant follow-ups, we have great help from the referring physicians and pulmonologists. They do these surveillance bronchoscopies and send them to us only for the biopsies. We have a lot of help for medical management also when it comes to the general pulmonologists who take care of our patients. So that way, I think we have kind of taken care of the geographical barriers.
Okay, but Tapaswi, let me ask you, you're talking about patients from Delhi and Assam, which I understand it's a very far away. But let's say you've got a patient who lives 3 hours from Hyderabad. I'm just giving you an example.
I wouldn't shift him. Yeah, it happened to me also recently. So patient was from Karimnagar, that is like 1.5 to us. We have not shifted him. To us is easy. We can manage, but not up north, above Vindhyas and Satpuras, no.
Okay, fine. And my last question to end this discussion is directed to Jnanesh sir. Jnanesh sir, by some magical wand, there's a process in which you are now the in charge of lung transplantation in India, let's say, okay, as we're talking hypothetically. What do you think are the things which must improve for timely referrals?
Kapil, very thought-provoking question. To increase referral, for example, if you are staying in Mulund West, my suggestions would be, or what I would do, as you have asked, or what would you do, or what would be my suggestions is, I would first find a person who is a paramedical or a alternative medicine specialist to help me make a list of all the associations that are there, all the hospitals, medical colleges, the Rotary clubs and Lions Club, these things, and let him arrange 2 lectures, one on Saturday and Sunday and one on midweek. So you are giving 3 talks, because I think the key to all this referral increase is education, and education with the help of this thing. So if you give this same talk and what you're doing right now, webinars, which so many, maybe hundreds of pulmonologists are watching you, this would help increase referrals. The other thing that I think about is that you're giving these talks to family physicians, to general pulmonologists, to internists, and to cardiologists, because cardiologists form a big chunk of referral because they have patients of pulmonary hypertension. So they can refer you patients for primary pulmonary hypertension and for Eisenmenger's for your both lung and heart-lung transplantations. Other thing one can do is that you can have these what cards you displayed, the slide that you displayed for interstitial lung disease. Like that, you can form a laminated card and give it with your name on it to the pulmonologist with your telephone number so that they can keep these cards in their view box, one card on their view box. And when they come across a patient who they think may be a candidate for lung transplant, depending on those criteria, they can call you and ask them to get educated more about lung transplantation from you. This would be my suggestion.
Okay.
The other thing is that once you finish this one series of talks in a particular area, say you take Mulund East and Mulund West, and you finish these talks, you make sure that you do 3 cycles of that. So you meet these people 3 times over a period of 3 months or 4 months, this thing.
So constantly meet up and keep sort of refreshing their memory as to the talks and everything.
After covering up one area. So you choose an area, choose all the Rotary clubs, Lions, medical colleges, hospitals, tertiary care centers that are there, and all the associations, that IMA or Ward B association, these things, and give them talks. You should be talking 3 times per week for a period of 3 to 6 months. If you do that, then you will be this thing.
Got it. Anyway, sir, thank you so much for your answer. It's wonderful to look at all these aspects. You told me it's a penetrating question, but I would tell you it's
one more thing. There is one more thing.
Yes, sir. Go ahead.
Dr. Bhavin Jankaria has a newsletter. It's a single page. So with your writing skills, you can write one episode or one case history or one transplant pearl, lung transplant pearl in a newsletter and circulate to all the doctors in Bombay and New Bombay.
Got it.
Would be one. This is what Bhavin Jankaria does. I get one CT scan. He obviously he's a radiologist of great repute and this thing. So he sends one every month. I get one newsletter from him.
Wow, definitely something to ponder upon. I think points very well taken, sir. And penetrating answer is what I would say. Sir, to all the panelists, quickly, we've got only 2 questions from the audience. So the first is by Dr. A.S. Rangarajan, sir, in Coimbatore. Is lung transplant only living donor or cadaver donation? So anyone can take up this.
It's a cadaver donation.
Okay.
In India, it's a cadaver donation program.
Okay.
Living lobar transplants is yet to come into picture, especially for children with cystic fibrosis. Could plan 1 lobe of the lung from each parent, yet to become a reality.
Okay, got it. And the second question,
that was a Kapil, just to add, that was I think from Japan. There's a good program that was running in Japan. I don't know whether it is sustaining now or not. But it was a successful program, except for the close to around 3 to 4% mortality in the donors. That's the big number. Okay, close to 10 years back. I'm not sure about the current data.
Correct.
Yeah, Hiroshi Date, he's a exponent of that. Japan and Korea are the only places it's being done, especially for
moved to US right now.
Yeah, I think so. So I don't think live is happening in India anytime soon, basically.
And the second question is by Dr. Mohammad Danish from Udaipur. What are the investigations needed prior to lung transplant? Again, anyone can take this question.
So it's a comprehensive evaluation, especially we need to look at the severity of the disease, to look at other to try to catch other comorbidities like cardiac, renal, any detected malignancies. So there will be and also to see the immune status of the patient, whether he's sensitized, whether he has anti-HLA antibodies, any occult infections. So we typically scan, chest or abdomen, and then also other specialists to look at each organ system, make sure everything is working fine. That's in essence the immunological part. There is a severity of disease, whether he needs transplant or how soon he needs transplant, what kind of transplant, what are the comorbidities that can be fixed, cannot be fixed. Those kind of things are what we're looking for.
Got it. Okay. So, I mean, just to expand on what Dr. Ganesh Thacker said, I would just like to ask the other panelists, everyone very quickly, one statement, one thing which you would like to do to increase referrals for lung transplantation. We will start with Dr. Vijay Kumar Chennamchetty side. Garu, please go ahead. Just one statement.
So quickly, okay, we need to bring the awareness, okay, in the social media. That's what is one thing. We have to use all our Insta pages, FB pages to ensure that keep on at least as a interventional and then general pulmonology, clinical pulmonologist, we should do at least weekly once one post regarding transplant or some ILD related these kind of things that increase awareness.
Got it. Perfect. Indu, please go ahead. What is your suggestion?
So, Kapil, I feel the problem is not counseling. We are counseling the patients. The problem is from the fear from the patient. They think that lung transplant is like abandoning the patient or giving up on the patient. So I think that fear needs to go. The idea is basically that we are evaluating early and we are optimizing the process. So this idea needs to inculcate in the people.
Got it. Okay. Animesh bhai, please let us know your thought process.
Yeah, I think I dropped out just for a minute. So basically, you're asking for a sum of this thing or something specific?
No, just one idea which you feel we must do to increase lung transplant referrals.
As I said, awareness. Awareness. Use all possible medias, all kinds of channels, maybe peer-to-peer counseling, use word of mouth.
Got it. Okay, understood.
So I think we have to do that, but awareness.
Okay, got it. Quickly, Tapaswi.
We'd want to rope in non-pulmonology colleagues and doctors to understand the outcomes of lung transplant, show them how well post-lung transplant patients are doing. Because, of course, our pulmonology colleagues understand how these patients are doing. There is a gray area where our non-pulmonology medical colleagues think that it's a Herculean task to do a lung transplant. We probably should break that barrier.
Got it. Perfect. Beautifully put. And that is one of the things which these webinars are trying to do. And lastly, Vijil, sir, I would like your one comment.
Yeah, I think we should celebrate our success. We should put out the patients. The patients become our brand ambassadors, the word of mouth. Anybody who's interested in it, we can refer to patients whom we have done and had a good life. And that way they will get confidence that to undergo transplant. I think that's one way to do it.
Got it. So thank you so much on that positive.
Kapil, just one sentence I want to add.
Yes.
Is what Tejasvita and Vijil have said. There is nothing which convinces a pulmonologist better than a transformation, to demonstrate transformation. So when you go for all your talks to the pulmonologist, you must take with you one patient who has been successfully transplanted and let those patients interact with the people, the doctors with whom you're giving a talk. Exactly what Tejasvita and Tapaswi and Tapaswi and Vijil both have mentioned the same thing.
Got it.
If you're on it,
okay.
Yeah, on your talk, you take them with you.
And also, you should look at the other alternative. What is the other alternative? All of these patients are going to a relentless process. Eventually, they will die soon.
Absolutely.
When if there is, compared to other transplants, there are issues with lung transplant, but there is no other alternative which is can match this, basically.
Got it. I mean, quickly, we've got two new questions, and after that, we will wrap up this webinar. So, first is, does a lung transplant team require a CVTS surgeon as a team member? I love this question, and what a team should look like for a transplant. Jnanesh sir, ye to thoda pata nahi. I don't know what to say.
Yes, and yes. We need a transplant surgeon, and we need many of them. Trained transplant surgeons are a scarcity. Yeah.
Got it. And the last question is Lung Transplantation Day celebration. I think we recently had the announcement of a lung transplantation day, if I'm not mistaken, 2 weeks back or something. But I am not aware of any major national level celebration.
So we can keep it as 27th November. That was the day the first successful lung transplant was done in the world by Dr. Joel Cooper.
Okay, wow. And Vijil can invite us all for a party.
Quickly, Kapil.
Go ahead, sir. Go ahead.
See, first of all, what I see is in the conversations that happens with the patient families and patients, so there's a lot of fears. So particularly, so what happens is we need to be very transparent. We need to be under promise and over deliver. So if you do this, example, if the success rate of a transplant program at your center is, if well started, is close to around 70%, 80%, samjho. Okay. Say to them, it is 50% only. Nothing will happen because initially, don't promise, over promise. So under promise and then ensure that, few cases, probably, half a dozen of cases, okay, are brought to life successfully, and then they are having a reasonable good quality of life. I think if you do it consistently for few years, 2-3 years, I think the confidence levels in patients would be really sky high.
Okay. So under promising and over delivering. It's a good thought process. But on that note, I would just like to conclude this particular webinar. Thank you so much to all my esteemed panelists. Thank you, Dr. Jnanesh sir. Thank you, Vijil boss. Thank you, Tapaswi. Thank you, Dr. Indu. Thank you, Vijay Kumar Chennamchetty Garu, for making it after the hectic examination. And thank you so much, Animesh Bhai, for those lovely pearls of wisdom and for such a wonderful panel discussion. Again, remember, I would like to mention this is just the first webinar in a series of webinars which we are planning for lung transplantation. So there are going to be different aspects of lung transplantation which will be discussed in detail by subsequent moderators and panelists over the next 5 or 6 weeks. So please remember, this is just the opening innings. We've still got a lot more to offer. At the same time, I mentioned previously, but I would like to once again mention, thank you, CCI. Thank you, Krishna sir, Dr. Narayan Pradeep sir. Vijay Kumar Chennamchetty Garu is one of the panelists, but he is one of the forces behind these webinars. Thank you, Atri, Shivani. There are so many people. Ashish Dubey sir, Anil Maske sir. Thank you, Mankind, for for your support for this webinar. Thank you so much, all of you all. Thank you.
Vijay.
Thank you.
Thank you. Thank you.
Thank you so much.
Thank you.